Exercise is something that I advise all my patients with depression to do, at least 30 minutes. But of course, we come with a challenge of like, oh, I don't have the motivation to exercise. Then at least any amount of exercise is better. A lot of studies shows that exercise can be even sometimes as good as SSRIs or as antidepressants in managing depression.
Behavioral Health Integrations podcast strives to inspire the next generation of mental health and addiction specialists. Our aim is to continue to raise awareness and encourage collaboration in the mental health and addiction industry so that it will continue to thrive. There are numerous approaches to treating mental health and substance abuse issues. On this show, we take pleasure in showcasing the diversity of these approaches used to improve the lives of others. So without further ado, your host, Jacob Menig.
Dr. Bishoy, it's an honor and pleasure having you back on my show.
Thank you, Jacob. Thank you for having me.
Of course. So just to give everyone a heads up, we have a bit of a theme on the show today, not just mental health, but more of a certain avenue. And again, it's a real pleasure to have an expert on this matter, which is, again, depression in children. So I, for one, am truly excited to get started with all this. And again, it's a pleasure having you on, Dr. Bishoy.
Thank you. Appreciate it.
So again, the realm is depression, but not just depression, it's depression in children and adolescents. And Dr. Bishoy, do you want to inform us a little bit about that just to start off?
In our the Bible for psychiatry, it's called the DSM, Diagnostic and Statistical Manual for Psychiatry and Psychology. It's here actually. Now DSM-5 TR, but basically under depressive disorder, you find major depressive disorder, which is what we're going to be speaking about, but also other depressive disorders called DMDD or disruptive mood dysregulation disorder, and persistent depressive disorder or what was called dysthymia in the past. Yeah. We're going to focus more on the major depressive disorder, as I understand, Jacob.
Yes, absolutely. Can I make a little comment though? I wish the DSM would change that label. I don't know if it's just the major depressive disorder. I've had a lot of clients and patients over the past it's the major part that's just really, destructive of the human being and of the individual. And what are your thoughts on that just in general, just maybe changing some of the wordings of these disorders?
Within the depressive disorder, there's depressive disorder unspecified. And if it's used for those who do not fulfill the full criteria for major depressive disorder. I feel the word major depressive disorder is because it signifies how impactful it is and how it necessitates intervention of a very specific type.
Okay. So in your practice and in your work, when you have, let's say, a child in your office, whatnot, and you're assessing him, what are some what signs or symptoms are you looking for when it comes to the diagnostic of depression in children?
Yeah. So the first thing is depression alludes to the mood. So it means depressed mood. But in children and adolescents also can appear like irritable mood. So that's one of the criteria that we're looking at, if the mood is sad, low, constantly, dysphoric or not happy, and the irritability. And those can be subjective, as in the patient themselves can tell us, or objective, as in the parents can say, oh, they're extremely irritable. Like I'm walking on eggshells. If I say something, it's blow up. So that's one thing. Second thing we look at is the what we call anhedonia, which is the loss of interest, of pleasure in doing things. And that we see kids who used to play guitars, for example, they would be like, I don't enjoy that anymore. They used to be having hobbies like painting or listening to music, and they're no longer interested in that. So that is part of the anhedonia, loss of the ability to have pleasure in life. And we often see it also by parents' report as well. So it's very important, child and adolescent psychiatry, to get both perspectives, the parents and the child. Also, some what we call vegetative symptoms or physical symptoms, like lack of sleep, problems with sleeping. And that could be like insomnia, either inability to initiate sleep or to maintain sleep, or it could be oversleeping. Both can be flavors of depression, because depression has phenomenologically very variable ways that it can present itself, and that's why in the DSM they have specifiers, etc. But
Okay.
also, you know, the body, how it moves, is it becoming slower or is becoming very agitated? These are the things we look at. The thought content, like what are they thinking about? Are they thinking about negative thoughts? Is there any suicidal thoughts? Is there any self-harm? These things we look at. Also guilt, which can be delusional guilt. We see that a lot in kids, together with the fatigue and loss of energy. And so all of these are like some of the elements we really see. Appetite is a big factor with kids. So whether they lose appetite or sometimes they increase appetite as like some kind of a coping mechanism.
Yeah, no, I also want to add in a couple of things too. I know in one of the PHQ-9, and again, that's more of an assessment for adults, but one of them is like you're moving slowly, but you're also talking so slowly, people have difficulty understanding you as well. And I'm sure that's the same for kids.
Yeah, and PHQ-9 can be used in kids. It's a patient health questionnaire. That's what it's short for. Scores from 0 to 27, and it's kind of tells us it's a good screening test for depression. By screening means it has what we call high sensitivity, as in it can detect depression, but it doesn't really not specific, as in it doesn't say, oh, this is depression, but it says that this could be depression, and therefore we really want to do further investigation. We see primary care pediatricians use that a lot. And then if somebody is high on the PHQ-9, either they can initiate treatment or they can refer to child psychiatrists.
Excellent. Also, I want to add something else too about like another possible way depression could be just caused in a child. Like, what do you think about like today's environment? And that I know that can mean a lot of things, but like maybe the neighborhood the individual's growing up in, or what do you think about social media nowadays with children and how that impacts or could impact depression?
Yeah, that's a good area to think about. It definitely is contributing. Depression is have a lot of what we call biological vulnerabilities or genetic causes and environmental interactions. So it's a gene environment interaction. We know that it has a big role. Gene has a big role. Like twin studies show like around 60 to 70% heritability. And kids with parents with depression have like around 2 to 4 times more propensity to develop depression. So genes is a big thing for that. Now with the environmental interaction, that's why they both play together. So the biological vulnerability together with the environmental factor like childhood adversity, etc., traumas, but also social media. I believe that over exhausting mental resources in social media, and also the lack of socialization that comes, the lack of real, valid, tangible socialization that comes, but also the extreme amounts of comparison the kids do between each other because of social media, etc. Anecdotally, at least, we get a lot of patients in the clinic that talk about how that has been impacting and worsening and exacerbating their depression.
Yeah, and I don't know if this gets into the realm of like trauma, but now you have obviously bullying nowadays and social media bullying, which can also cause harm to a child's emotional health. So again, I wonder how much trauma can also impact depression along the way as well.
Yeah, absolutely. Childhood adversity and trauma do contribute to depression. And bullying in general is a major factor. We hear about it a lot. And it really, sometimes it just unmasks the genetic propensity for depression. But we see it quite often in schools and also online.
Mm-hmm. And another avenue we're going to get in this episode, which we could possibly get into now, is the parents and the important role they play in all this, where a parent may need to know the signs of depression or if their child is at risk. In your professional opinion, what are some signs a parent should look for in their child if they are going through this?
So firstly is like how their mood is. That's the basic, because depression is a mood disorder. So how's their mood? Are they irritable all the time? Are they sad all the time? That's a good signal to first, see that. Second thing is how's their energy levels, like the things we talked about, but from an objective parental vision versus the perspective of the child themselves or the subjective experience. So they can look at that. But also, I feel like a vigilant parent in general is extremely helpful in early detection of these things. Most of the patients with depression we get them from the um, counselors in school. Like they go and talk to the counselor, and suddenly the counselor realized that they have like self-harming behavior, they have suicidal thoughts, and they have all of this, and they end up in the emergency department. But more often than not, if the parent is vigilant, if he's looking or she's looking into, oh, my child is way more withdrawn right now, way more isolated, um, looks way more sad, crying more often, having more crying spells, um, and looking at, oh, I've noticed like weird, parallel, vague lines on his left arm. And it could
Mhm.
be that this is a form of self harm that has been beginning, or scratching, or he's always wearing, or my kid is always wearing like really long sleeves. And
Mhm.
I never see their arms anymore. And that could be like, huh, what is there something they're hiding? Like, and then it could be that they're, like anecdotally as well. In my clinic, whenever I get the blood pressure for the patients, and I made it a habit to take the blood pressure myself, I
Okay.
would look into the arms because more often than not, I would discover like some level of self harm that wasn't,
Mhm.
acknowledged, and the patient would deny it. The kid would deny it themselves initially, but then you can confront them once you see it, and it's important, like visually, for the parents as well as the appetite, all of these things are how long are they sleeping, what's their concentration and focus, how's their grades in school, are their grades in school declining. All of these things are like very important to factor in when you're like synthesizing the clinical picture of depression. So the parent's perspective is extremely important. Also, like a parent that is very well connected with the kid, and the kids can feel vulnerable to open up to and say things, they can share things like, oh, I've been feeling like I'm not good enough, I've been feeling guilty, I'm feeling like I'm um, feeling like a burden, and I'm feeling like those feelings of worthlessness, hopelessness, helplessness. All of these things can be shared with the parents once there is a good connection between them.
The classic line I always hear about is, yeah, the parent will briefly check in with the child, and the child will say, "Oh, I'm okay." Well, then you have to consider, like, okay doesn't always mean okay.
Right. There is way more than meets the eyes with children, especially that their um, linguistic and associative capacities are still developing. So they're not really able to really tell you what's going on within them. And sometimes you see things what we call alexithymia, which means inability to really tap into one's affective experience. Like we as humans feel like, oh, I'm feeling anxious because my heart feels like that way. Like the somatic experience of anxiety, we really are familiar with it. And we're having that correlatory experience that we can label with a word. For kids, it's sometimes like it takes them a while to identify their own internal environment, learn about how they feel and what is normal and what is not normal, and be able to express that in words, and not feeling guilty about expressing that in words, and all of these things. Like it's a very complex level of interactions that create that state that we call depression, and the child can sometimes struggle, especially if they have low motivation that comes with depression, to really, and lack of self-esteem, etc., to really open up to anybody, let alone parents.
Absolutely. Like, what I'm sensing from you is just how important, how powerful the connection relationship is or needs to be with the parent. And just a flip side, there's other scenarios where I will hear about the parents not believing their child. The child will go to the parents as, "Mom, Dad, I'm self-harming, I'm depressed." And the parents will be in denial. "No, you're not. No, you're not. No, you're not. It's not that happening."
Yeah, yeah, and that is the problem of invalidation. And it can be like the example you gave is a very like the severe example, which I feel could alarm any patients if parent if their kid tell them I'm self-harming. But if the kid comes and say, hey, the pressure in school is too much, I'm feeling really sad, I'm feeling like I'm not good enough, etc. And you invalidate that experience, and they're like, no, you're not, you're like this, just go and do it. And that invalidation makes the kid very reluctant on
Mhm.
opening up in any time in the future. So it's called a sort of training them that, oh, when I go and seek out help, that is the response I'm getting, which is severe invalidation of my feelings and my emotions and the way I experience the world and reality. And if I feel invalidated, then what is the point of sharing that reality with somebody else, like on an intersubjective level?
You know, it's interesting because the reason I brought that up is that when I was like sophomore, junior in college, I had a classmate who was self-harming herself, and she was telling me about it, and I didn't really know her that well. I consider her like a good acquaintance, but she was literally telling me, she was telling her mom, I'm self-harming, and the mom wouldn't believe her, wouldn't deny it, until it got so bad to the point where obviously the mom couldn't deny it anymore, and then finally she got help only when it got to the top levels of it. I don't know, extreme
Yeah,
emotion.
like a very high threshold. I understand. Self-harming is a big separate issue because self-harming transcend depression only. Like self-harming can, we actually have a different label for it. We call it NSSI, or non-suicidal self-injury.
Okay.
The reason we use it that way is that self-harm is a more of an bigger encompassing term, which can include like driving recklessly or things or smoking, etc. But NSSI is very specific about deliberate self-harm that is direct and that is not culturally acceptable. For example, if somebody puts an earring, that's a form of but that's a culturally acceptable one.
Mhm.
So that's why it has that image about it. Now, NSSI can come from so many reasons. It can be from personality disorders like borderline antisocial. Substance use can trigger that. Depressive episodes, 100%, can lead to and can contribute to that. Anxiety disorders, etc. But also can come from trying to connect with a specific friend that they see, or kids that are imitating each other, or a form of attention seeking. So you have to be like very cautious when there is self harm, and very very curious into what caused that. And the distinction of the reason we call it NSSI, or non-suicidal self-injury, is because of the intent of the kid. So
Mhm.
it could be the same cut that you see, but it could be the intent of it is like, I want to end my life, versus I want to just relieve myself from psychological pain, which is often what's causing NSSI, is that they want to like move the psychological pain into a physical pain because that's more bearable and more they're able to navigate that easier.
I'm so glad that you brought that up because that was going to be my next series of questions. Was a lot of the times I'll get fellow professionals or just lay people coming to me and be like, they're just totally oblivious to this self-harm and SSI thing where people would harm themselves, and they would ask me like, why do they do it? I don't understand. Why do they cut themselves? Why do they do this? Why do they do that? And my thing is, like, a lot of times when I hear from those patients and clients, they sometimes experience a feeling of numbness, like you're referring to, like a mental emotion, and they want to transfer it to like an emotional feeling. It's just they want to feel something. And again, that's obviously not everybody, but that's for the ones who came to me. It's just a numbness where they want to start feeling it again in some way.
Yeah, and that could be like that, to overcome that feeling of numbness or feeling of emptiness, which we see sometimes with personality disorders like borderline,
Mm-hmm.
and or to change or transmutate that emotional pain into a physical pain, because it's almost like that overcomes somatic experience, always overcome like the mental or narrative experience. But it also can be a form of self punishment if they have like severe types of guilt. It could be like the reasons or the causality chain of self harm is heterogeneous and enormous. But and that's why we really want to dig deeper in a personalized manner whenever we see self harming. It's something that's very alarming, and we often have to send them to the emergency department to be assessed for sure. And but besides that, when they're being assessed, you really want to sink deeper into why are they self harming, because self harming can develop like almost an addictive quality to it.
Yeah.
Our brain reward system can be, if you relieve, it plays with association, almost like conditioning. So that area in the brain, like it's called nucleus accumbens, shines when that act is happening, and it starts developing that association. Then it starts, creating almost a craving for it
Yes.
at some point.
Yes.
Yeah.
Okay. So now let's move on to the scenarios where the parents understand the signs and they're aware of their child and that the child is going through this. Do you have any advice on an approach a parent or a parents should take with their child in helping them with this issue?
Yeah. I think the first thing I think about is definitely, if you see signs of depression, is go to a professional.
Okay.
Go to the pediatrician or go to the psychiatrist, or go to the pediatrician who will refer you to a child psychiatrist. The reason is that depression can happen because of biological reasons too. So when we get a kid with, or a child or adolescent with depression, we want to screen for, thyroid issues. We want to screen for, is there anemia or not? So we get the complete blood picture. We check on their liver, we check on their kidneys, we check on the body. We do blood work in order to check that. Also the vitamins like vitamin D, vitamin B12, etc. So really, we want to rule out if an otherwise physiological reason or a medical reason, or what we call organic reason, that could be contributing to exacerbate or worsening or causing this depression that we're seeing, and just labeling it as depression and trying to target depression when it's actually something different and
Okay.
something organic could be you're not treating the right thing, and could lead to medical consequence. So that's the first thing, to go to a professional and get your child or adolescent assessed, and whether they need to be referred to a child psychiatrist or not could be from the pediatrician, or you can directly go to a child psychiatrist. Now the treatment, first, it depends on the severity, it depends on what's going on, depends on the assessment. So depends on so many, as you know, it's extremely nuanced to determine the line of treatment. But in broad scopes, it's psychosocial treatment and medication management. Whether you will do one or both, that depends on the severity and the decision of the clinician or the psychiatrist seeing the patient. Psychosocial treatment can be what we call CBT, or cognitive behavioral therapy. Interpersonal therapy works for depression. Also, family therapy can be very helpful. And things like psychoeducation, or educating the parents or educating the child about the symptoms and not making them feeling alone. And the medication management are the medications that target depressants. Broadly speaking, they're called antidepressants.
Okay. It's very interesting. So you're all working together as a team where you would again refer them to a child therapist who could do, like you just said, interventions like CBT, DBT, internal family systems, interpersonal relationships. Yeah, that's all great stuff. It really is.
Yeah. It's a definitely multidisciplinary approach. Whenever there is depression, or whenever there's a mental illness in general, you want to work up really closely with the pediatrician, and have good communication with them, and just exchange information, exchange perspectives, and reach a coherence about what you think and how are you going to do an intervention for that.
Okay. I'm wondering, and again, I don't want to get too much into this because again, I know all doctors are different, but if you were to go the antidepressant route, and let's just say it doesn't particularly work, I'm sure there's is there normally a feeling out period with antidepressants? Because I know they could be somewhat dangerous at times. Like you try an antidepressant and it doesn't work on an individual or child, a doctor may want to reassess and put them on a different one, or how would that work? And again,
Yeah. I mean, antidepressants work a little bit differently. And firstly, interestingly, in child and adolescent populations, the placebo effect is way more than in adults. So especially when it comes to mild and moderate depression, the placebo effect is more. But our medications, like the medications that are at least approved, do separate from placebo, meaning that they have an effect that is superior to placebo, though depression, especially mild and moderate, are placebo prone diseases. Now, with that being said, if a medication doesn't work, that doesn't mean the end of the trial. Firstly, is the dose adequate? Is the duration adequate? That's the first two questions you want to ask before switching. Now, if it doesn't work, then you follow the algorithm. You switch to another medication, initially of the same class. Unless you have something totally different that you're dealing with. The one we usually utilize is under the umbrella of SSRI or selective serotonin reuptake inhibitors, and they increase serotonin.
Is it true though? Sometimes like anti-anxiety medications as well could be used as an antidepressant. I forgot the term it's called when you use a medication for something that it's not used for.
I think it's interchangeable because both anxiety and depression typically, for the most part at least, have some very close biological imperative in them. So you use the antidepressants, they do target anxiety as well. For example, like a lot of medications approved for major depressive disorder are approved for generalized anxiety disorder, and they are used also in panic disorder. So the anxiety, and they're used also in obsessive compulsive disorder, which is an anxiety disorder. So you can see that you can use one in treatment of another. And
it's called off-label, right? Is that the term? It's off-label use.
Yeah, off-label is when a medication is used for something that it's not approved for, but you can, as long as you are able as a psychiatrist to develop the rationale of why you're using that medication off-label. We use often off-label because it takes a lot of studies for something to become FDA approved.
For some of you, this might sound unusual, but I believe trazodone has also been used for antidepressants.
Yeah,
trazodone is a sleep med.
It is an antidepressant on a higher dose, and we often use it for sleep. Most of the people would use it mostly for the sleep or hypnotic qualities.
It's very interesting because I've seen other interviews with people and they talk about medications where their brains just work differently. Where this gentleman said, the things that put you to sleep stimulate me and wake me up. The things that stimulate you put me to sleep. That's just how his brain works when he takes in medication. Because we're all different from a biological perspective.
Absolutely. I think that's the part of where psychiatry in general, and at best, studies are generalizations, right? Like studies which say, oh, this works because of this. You're generalizing the evidence base, which is excellent because that informs our decisions. But then every person, the nuanced presentation is extremely unique. And you really want to sink into and visualize mentally, like at least my approach is to not only visualize how they look in their own day-to-day life and have like a clear mental movie of how their day looks like and how their interactions look like and how their arguments look like, but also try to visualize and understand and feel the neurological experience of what's going on. What kind of neurotransmitters imbalance are happening in this, and how are we going to approach it? Factoring in all biological reasons, developmental, pathway, the milestones they reached, their medical comorbidities, etc. You're just like synthesizing the clinical picture from so many broad scopes and assembling that into the impression that you are trying to target.
And top of my head, I'm thinking about a couple of other interventions that are sometimes not really looked at. What do you think, especially for children, nutrition and exercise? Do you think they need to be promoted more in the overall health of children, especially in today's society?
Yeah, absolutely. Exercise is something that I advise all my patients with depression to do, at least 30 minutes. But of course, we come with a challenge of like, I don't have the motivation to exercise. Then at least any amount of exercise is better. A lot of studies shows that exercise can be even sometimes as good as SSRIs or as antidepressants in managing depression. And food intakes, of course, like in general, a healthy diet, that one that doesn't promote inflammation in the body. There's a big association between inflammation and depression and mental illness in general. So definitely a healthier diet is one that is we advise on. Yeah.
And another aspect too that we have to think about, for a lot of places, food can be expensive, especially good healthy food. So I could just imagine a scenario where you're telling a patient's family this, but like they, just can't afford a lot of things. And for some people, it's just cheaper to get McDonald's on the dollar menu or whatnot to get food. And again, it's a sad situation scenario that a lot of families have to go through. But again, sometimes families can only afford certain processed foods for their kids.
Yeah, and that's very unfortunate. I really don't have a clear answer of how we can solve that, because it's just as a much bigger scope of reasons, including that healthier food is way more expensive than processed food, and the accessibility, and also the glamorization in the media, etc. So there's so many factors into this problem that you're alluding to, and it needs a very zoomed out, systematic perspective in order
Mhm.
to tackle it. And so I don't have a clear cut answer, but yeah.
Absolutely. No, but as we both know, it's very important. Now to the next part of the interview. Again, I'm very excited to be talking about this as well. So like I told everyone, Bishoy was on my show before, but a lot's changed for him, and I believe he's working on a new project for himself right now. And again, Dr. Bishoy, we would all love to hear about it. And what's it called?
Oh yeah, so it's not new. It's been in the works for many years. I'm collaborating with a group and advising as well. Uh, Basically, the something I'm passionate about, because it's about furthering the education of parents on depression specifically. So you know how now most of the information is through podcasts,
Yeah.
through listening, and it's less and less drifting away from reading. And you can see that in a parent who's busy, who in a mother, for example, let's take a mother as a use case. So it's very extremely busy. Um, Her child has just been diagnosed with depression, or she doesn't even know what is depression yet. She can go and buy a book, which is great, but she, between her and the two kids that she has, and getting them from school and working and all, it's extremely difficult for her to get information in an easy way that would be further her psychoeducation as we speak about depression. Now, I've noticed that there is a huge trend of podcasts, of spoken media, and we're speaking in one, right? And especially ones that are tackling depression, mental health, wellness, flourishing from so many different angles, and really interviewing experts. And I felt that information, though it's diverse from different sources, it would be really helpful to have what we call knowledge nuggets, as in short excerpts of those videos, so that um, they are targeting one information, an informational unit, and creating from that multiple playlists from different sporadic areas, in order for the mother, whenever she hears that, she gets to answer one comprehensive question. So that's broadly speaking. And also, I feel like that project, which could be, manifesting as an app, or as in the future, like a website, um, would also facilitate communication between people facing the same situations. Not as a direct, that's not a substitute, or by any means, from any direct recommendation that comes from the physician, etc. But sometimes just relating to the problem and understanding it more, understanding how what are the symptoms, etc. Because we have like thousands of hours of material online from
Mhm.
experts, but uh, the amount of psychoeducation that is available within the clinic realm, or within the encounter with a psychiatrist, or within an encounter with a psychologist, though
Mhm.
it would never be as long as the accessibility, availability of having just to put your headphones on and listen to something while you're exercising, what we call lean back learning. or while you're cooking, or while you're cleaning, or getting to know more about what's happening with what is depression, what are the treatments, what does the depression even mean? What is it biological? Is it like this? All of these things I think are important for parents to know. So it's a really an educational, at its core, it's an educational system.
Yeah, I think it's great because, like, as mental health professionals in this field, we have to adapt to the times. And I just love your idea of the app because, again, like that's how a lot of people retain their information now rather than the book. So again, it's a great, fast, quick way, but knowledgeable way and valuable way to again gain knowledge on subjects like this. So
Yeah, and it's, um, I mean, it's something that I feel would add value to people, specifically in regions where there's a lot of stigma and there's a lot of like mental health is a big taboo. And I feel like giving that access to those populations and mothers who really are not familiar with what is that and are shy to ask or don't have the available resources to ask and really want to learn at the same time would be something that would be adding value to those people allowing that knowledge to come to them so they can help their kids better and help feel better about it and understand it deeper. Once the parents understand it deeper, then it translates directly to how their child would be doing. So yeah, yeah.
that's a beautiful thing. It really is.
Thank you, Jacob. Yeah.
And also, I'm really fascinated in how you're going to utilize AI for your services. Could you get into a little bit more about that? I think that's really cool.
I mean, broadly speaking, we have like a part of the team that's working on this is world-class, really, AI and computer programmers, designers. We also have conflict resolution experts from the big universities, meditation. Like there's a big team. But in general, the part would be how to assemble and synthesize that learning line in order to be the most efficient way for you to learn that information. So let's say you want to learn about what is depression. What would be the sequence of things you listen to in order to give you a very good holistic idea of that? Now, let's say you want to learn about the treatment modalities, etc. So I think that that's where probably as you're very familiar, large language models, etc., is a huge thing now, and everyone is trying to utilize and capitalize on that available technology to further help us as human beings in alleviating our suffering, really. And a big part of like huge cause of disability is depression in kids. It's one of the main causes of suicide, and it worsens the quality of life so much. So if one can really contribute in any way, especially through education, which is available but not maybe as accessible, is something that I feel strongly passionate about. Yeah.
That's so cool. I love that idea of just like, especially an app and then the AI aspect of it where, yeah, if a culture doesn't know about this or an individual who has a culture that's maybe unaware on certain things, they could go to this app or its AI service and start from the beginning. Like, okay, I have this is what this looks like. What are interventions? What are the routes I could take? How can I find a psychiatrist? How can I find a therapist that's best for me in my depression or whatever? Some really that route or a map to, again, aid their mental health and so forth. So that's awesome.
Yeah, and I feel I see it as more of an adjunct or something that would really help further the information that is initially provided by the professionals. If somebody has curiosity to learn more, then that's an avenue where they can have that curiosity satisfied further.
And you know what I think is a really huge message too to get across is that they're not alone. They're not alone in their suffering. They're not alone in these depression symptoms they're going through. And that in itself is just, I feel like, so beneficial that they got help, they got support, and other people go through issues that are similar to theirs.
Absolutely. And for the mothers to know, like, for example, how to validate a child, etc. Again, I'm talking about populations specifically where they have zero access to that. Even countries which have zero access or very minimal access to that, and socioeconomic backgrounds where those educational spectrums would be very, very difficult to have like a really easy access to.
Excellent. Well, thank you, Bishoy. I think this is all amazing, great stuff. And again, it was such an amazing pleasure having you on my show again. It was an honor.
Thank you, Jacob. I appreciate it. Thank you for having me.
I again want to thank Dr. Bishoy for being an awesome and amazing special guest on my show. We all really learned a lot from him, and I cannot wait to continue working with him. I just want to thank all of my listeners for your support, and just to inform everyone that the information expressed in this episode was not meant to be taken as therapeutic advice. If you do find yourself struggling with any type of mental health or addiction issues, please seek the care of a medical doctor or a licensed mental health therapist. And if anyone has any further questions for me, you can reach me at my email address, behaviorhealthintegration121@gmail.com. You can also find me on LinkedIn at Jacob Minig, where you will find more educational posts on psychotherapy, trauma, and addiction. And finally, you can follow me on my website, which is behaviorhealthintegration.org. I also want to inform everyone that there is a great new device out there called Calmigo. It's a breathing device meant to control and manage your breathing rates and the depth of your breathing as you inhale and exhale to again help relieve any type of anxiety and stress-like symptoms. And if you do put the BHI podcast into the promo code, you get $30 off this amazing device. It is a once-in-a-lifetime deal, and you will not be disappointed. All right, everyone, until next time, have a good day. Bye.